So it's my pleasure to introduce Dr. James Buxbaum. He's Associate Professor of Medicine at USC and really a pioneer in a number of techniques in terms of reducing risk of pancreatitis in patients, in terms of ERCP in the US. And just a pleasure to have you here. So James, thanks for coming.
Thanks, Tom. I want to thank the Southern California Society for inviting me to give this talk today. So it's a practical talk. We're going to look at the need for stone removal, fundamental basic techniques, difficult stone, advanced techniques, and then a few fun cases at the end to challenge ourselves. So about 700,000 Americans have common bile duct stones in the United States each year. And the question is, do these all need to be removed? The answer is yes. The majority will have symptoms, and about a quarter will develop a major complication such as pancreatitis or cholangitis. What procedure should be done? We recently did revise the ASG guidelines to risk stratify, and looking at the world's literature, we found is that only patients who have definite stones on imaging, bilirubin greater than 4 plus a dilated duct or cholangitis should go straight to ERCP. Those with kind of lower risk, you should think more about MRCP or EUS or just lab chole with an IOC, intraoperative cholangiography. So the first tip and trick is to open up the orifice. You want to go in the 11 o'clock direction, obviously, to trace out the bile duct. The second part is to make sure you cut enough. We call it the county cut at LA County, USC. You think about the mound by putting in the first third of the tome, and then the instrument makers have been very helpful that they actually have different markings. You could then go 2/3 in, bow again, and then you actually cut the sphincter. Specifically, you're going for the sphincter choledocus because you're going the 11 o'clock direction, and that allows you to remove the stone. The most fundamental technique is balloon extraction. A tip and trick for this is don't get too greedy. You want to start at the end of the duct and then slowly work your way up proximally. Otherwise, you can impact. Another tip and trick is that you want to deliver it slowly, kind of like when you're on your OB. Oh, this one's not playing. On OB rotations, you don't want to move too quickly because things can get jammed or impacted. Classic basket extraction actually uses sweep baskets. Now, these are a misnomer because unless there's a coil and a reinforced system, they're actually just to pull stones out. The advantage of these are less likely to impact because you can grip the basket, and in some cases, you can actually perform sweeps. Rather, you can perform lithotripsy with them. They can be challenging to get in because they are stiff, so you actually have to reverse the direction 90 degrees. I use what's called the reverse pole vault. You can see it up here. You push in the duodenoscope, you bend the basket, and then you push it up, and that allows you to get that 90-degree turn to get up into the duct. And then you can then grip the stone and pull these out. If you need to, you can fracture some of the systems. But again, these are more sweep baskets. And then don't forget that stents are still a tool, a basic tool for stone removal. 90% of stones will decrease in size with stents, and they can be used as destination therapy even for up to a year in some studies. But we'll get you to the next step. And I like to do bilateral pigtails because it's kind of like a windmill where you're grinding up the inside of the stone or churning butter on the right side. You're kind of churning that stone up out of the stents, and something not to forget. So now we're embarking into the more difficult territory, the difficult stone. So what makes a difficult stone? A few considerations. One, it is the shape of a stone. If you have a stone that's shaped like a barrel or a piston, it can be hard to grip. If it's facetted, you can see here in the middle and the right, if they're stacked, you really can't get baskets around them and really manipulate these well. And of course, if the duct is sigmoid shaped, like in the left lower quadrant there, or if it's very narrow, this can be a problem. Some remember the study at Desario looking at balloon dilation versus sphincterotomy. If you do balloon dilations, they are as effective as sphincterotomies. However, there's an 18% complication rate, including fatal pancreatitis in randomized trials, which causes some pause. However, now a very important technique for the difficult stone is papillary dilation following sphincterotomy. And the idea is you perform a small sphincterotomy in the 11 o'clock direction and then perform the dilation. And that directs the force really in that bile duct direction up to 11 o'clock and away from the pancreas, which is more 2 o'clock. A few tips and tricks for this. You want to put about 2/3 of the balloon inside the duct, 1/3 outside. This allows for unidirectional force. The other thing is you don't want to dilate more than the duct size. You can actually disrupt the duct. You can get air emboli, a lot of other bad things if you do this. This is showing some of the approaches. They do make devices as one where it's a combined sphincterotome and balloon dilator. These are larger balloons, 12 to 18 millimeters actually. And once you get in the duct, you then proceed with sphincterotomy. And then they can introduce the bile duct dilator, which slides over the same tomes. But again, you can exchange as well. There's a variety of different kits you can do with this from different makers. But this one, you can see the balloon is behind the tome. And then the important part, of course, is the dilation. So again, you want to go to the duct size, and typically these are big stones because you're using these in more difficult cases. So they're in the 12 to 18 millimeter range. The cut, again, allows you to go in the 11 o'clock direction with the force and avoid the pancreas at 2 o'clock. Looking at fluoroscopically, you basically obliterate the waist of the papilla, and that allows a much bigger room to remove the stone. And you can see here's what we call the remodeled papilla after. You could probably drive a truck through this papilla now and get out whatever's in there within reason. So we looked at a meta-analysis on first procedure removal, and certainly with papillary dilation following sphincterotomy, there was a greater clearance, a 2.8-fold compared to sphincterotomy alone. And the adverse events and need for are quite comparable. It also lowers the need for mechanical lithotripsy. So the other kind of secondary technique is true mechanical lithotripsy. So this is after you failed basic balloon or basket extraction. And for these type of systems, you do need a basket that has a reinforced tip. Additionally, you need a coil sleeve. So you have to have those two components. And then you need some type of cranking apparatus. So you can see the difference of what these baskets look like. On the right is a true mechanical lithotripter, and the left is more the Dormier or sweep type baskets. And what happens, for example, is we're using one of these baskets and unexpectedly you get trapped in the stone. And then if it's a rescue type, which I tend to use more of, you'll cut the handle. You'll then pull the scope out, leaving the basket and the wire. I like to strip the sheath, although that's debatable, but you basically have a wire in the basket. And then you hook the wire into a cranking apparatus. So again, you have a wire, you have a basket. You start to crank and your coil moves slowly. You can see what this looks like on fluoroscopy. It looks kind of like a small scope, but it's a metal coil. And at the very end, you have to go very, very slowly. It prevents you from breaking the wire. And then inevitably, whatever is between the tip of the coil and the tip of the basket will be destroyed, and it'll free your system. Now, papillary dilation and reinforced baskets do have limitations for very large stones, more than 3 centimeters, or if they're very hard and they're breaking multiple baskets, or if they're facetted, you have to think about other techniques, which gets us to the final frontier of endoscopic therapy. And there's a lot of energy in this area. It's intraductal stone therapy. So this involves laser, which creates an aqueous plasma cloud, which can fracture stones, or electrohydraulic lithotripsy, in which a high voltage spark creates a shock wave. And with both these techniques, you want to be 1 to 2 millimeters from the stone, so you allow the wave to form. If you're too close, you just kind of drill into it. And you need to have a good guidance approach. So classically, in the 80s, 90s, as it started with fluoroscopy, but this was kind of blind. Percutaneous approaches can be used, but there is more bioleaks, hemobilius. So we tend to do these more with pearl cholangioscopy. There's been several iterations of this. The mother-baby scope on the left was quite fragile, required 2 operators. The slim scope is good, but you do have to have an anchoring system. So you can see it's a huge balloon because you're actually putting a scope all the way from the mouth into the duct, which is quite a challenge. And the newer are the single user, single operator cholangioscopes, which allow 4-way deflection, allow different capabilities. They do have some costs associated though, so hence the stealth bomber analogy a little bit. And the goal then with these is you can very quickly disrupt and fracture stones under direct guidance. You can see we're looking in the duct and the stone will fracture fairly quickly. Typically, we start around 10 watts of power, and this can be increased to 15 or even 20 in more serious cases. You can do really extensive work with lasers. I tend to favor them because we'll do multiple stones in my shop. But you do have to watch a little bit because they can poke through the distal end of the cholangioscopes. So if you see your laser light stop, that means you've probably poked through the side. And so you may have to basically pull the fiber out. You actually can just cut the fiber and put it back in and then use it some more in most cases. A few tips and tricks is there's several approaches for really hard stones. One is drilling. You just aim really in the center and you keep working and working. As you do this, the integrity of the stone is damaged and it starts to fracture and crack apart. And it's a drilling technique. And then there's a laser saw. So this technique, you can either move your shoulders from left to right, or you can use the dials from left to right. And you're basically sawing back and forth, kind of like what's done with laser and making diamonds and emeralds and things like that. And you just work back and forth slowly for very, very hard stones. My group did a randomized trial comparing reinforced mechanical lithotripsy to laser, and we randomized 60 patients at 2-to-1 ratio. And we did find that there was greater success with the laser, 93% versus 67%, were cleared endoscopically. The rest did require surgery in both arms. G. Young Bang and Scheinwerder Julia, Florida, recently published a nice study comparing cholangioscopy-guided laser therapy with papillary dilation following sphincterotomy. And they did find a similar story at about 94% laser cholangioscopy-guided therapy, intraductal therapy for these difficult stones versus 73% for large balloon dilation. And the real difference in their study was for those patients who had a stone size that was bigger than the diameter of the duct, and you really had to use a cholangioscopy-guided approach. So electrohydraulic lithotripsy is also guided by cholangioscopes. Again, we typically start by aiming at the center and then fracturing. You tend to want to start a little bit lower and work your way up. The issue is if the power is too high, you can actually fracture the cholangioscope lens and cause a lot of interference. I tend to do 5 pulses per foot pill activation as well. Once you do that initial fracturing, then you can kind of work on the hinges or the sides, or sort of like the donut, the sides of the donut, and kind of break these apart. It allows you to mobilize the stones. They're really great for oblique stones. So it's kind of like with APC therapy, it's more of a circumferential. You can get stuff off to the side. It's especially useful for intrapaddock type work. The Hopkins group did, actually, it was a multi-center group of us, looked at this and pretty comparable results for laser versus EHL. So it kind of depends on local factors. Adverse events, my team did a systematic review looking at this, and for the true difficult stone, it's actually very similar adverse events. For non-cholangioscopy-guided therapy, it's about 9%, it's 8% for cholangioscopy-guided therapy. But again, these are for difficult stones. There is a higher overall rate of adverse event. The important thing, though, is with cholangioscopy therapy, you are infusing aqueous, either saline or water. So there is a little higher risk of cholangitis. So you tend to want to think about stents in these patients. So here's a few fun cases just for the end here. So this was on Christmas Eve. I was supposed to go to a party, and this lady came in with this huge stone, and we used a reinforced basket, and we got caught. And then we were pulling, and we ended up just cutting the basket, pulling the scope out, and you can see the wires are caught there. And we started to grind with our Sahindra system, and then the wire snapped, and the Sahindra was too hard of a stone. So now we were stuck because we'd broken our wire, and we had a basket and a short wire left. So what to do? So luckily we did have a cholangioscopy system. We put the cholangioscope in, and we're looking inside here, and you can see there's the wire of the basket, and you can see a stone. And then luckily we own a laser, so we started to do holmium laser therapy, and we were able then to free the whole system, both the stone and the basket. Here's another case, is an intrapaddock stone. As you can see, there's a large stone here, and the cholangiogram, it's interesting, it doesn't even fill very well. It really had to do a balloon injection later to see that. And what would be the best strategy here? Laser EHL, or? So this is a good one for EHL, actually, because it's so oblique that with EHL, you can shoot more of in a circumferential way, versus laser has to be very focally pinpointed. So this was a great one, where then we're able to break up the stone with EHL, and fracture it, really clear that whole ductal system. And then there's actually now baskets that go through the cholangioscope, so we're able to then focally remove all the stone debris and stent and take care of this patient. This is a fun one. Recently, an older gentleman came in 70 with a lot of nausea and vomiting. He had CT, and what do you see here in his gut? Huge stone, 4 or 5 centimeter gallstone somehow got in there, fistulized through the gallbladder into the duct. So we encountered this giant gallstone, and we tried to get it out with Roth nets and forceps, and it was completely jammed in. So what to do? So you kind of apply your principles of stone removal, your tips and tricks. So we actually just put a laser fiber through the endoscope and then started to infuse saline and do our usual thing. One caveat though, it did break slowly. We did have to go to 20 watts. We had to go to the highest possible power, but we were able to clear this whole thing and he did avoid surgery. A little sore for a few days. Last case, a 40-year-old with a right requirement pain. The liver tests were minimally abnormal. So following our guidelines, we did get an EUS first and saw some debris in the duct. There's just some little linear areas here, some sludge. So we thought probably go to basic techniques. So we just went with balloon and some simple sweep baskets. That's what we found. Luckily we're gentle with our balloons. We didn't pull too fast or too hard. And we were able to deliver this whole liver fluke intact. It wasn't actually stones, but felt better. We weren't able to clear all these out. So we had to give some antifungals and things, or antihelminthics for this one, but took care of it. So in summary, for bile duct stones, they do require therapy. It is recommended that these patients probably in a lot of cases do need an MRI or an EUS, unless you do have biliary 4 or dilate duct, the combination together, or definite stones or cholangitis. For your basic techniques, probably the best tips and tricks that I know are for the balloons, do start distally. Don't get too greedy. Try to avoid impacting. For baskets, you can use that reverse pole vaul, precisely grab and slowly deliver. And don't forget about stents. They are part of basic stone therapy. The difficult stone, it's a variety of features. Stone itself, if it's barrel or piston shape or facetted. It can also be the duct. The duct may be too sigmoid or too narrowed. And it can also be that the stones are just too hard. You're breaking too many baskets. And then you have to think about your advanced techniques. So there's reinforced basketry. You know how to use these, either rescue type system or the coil that goes through the scope, or also those types. But also have a backup plan, because these can also fracture. So you should have some familiarity with cholangioscopy guided techniques. Balloon dilation, remember to cut first to avoid pancreatitis and not to dilate to a greater size in the duct. And for the intraductal therapy, these are guided with cholangioscopy. Make sure to infuse aqueous solution. Keep your probe about 1 to 2 millimeters distant. And then following that, use stents. It's a bit of dealer's choice, but I'd say lasers are more durable if there's a lot of burden. BHL is great if you have more oblique type things. And kind of keep the stone pyramid in mind. Basic stuff, again, balloon baskets, stents. You work your way into papillary dilation, mechanical, lithotripsy, and the intraductal stuff at the top. And you'll be able to get to your goal. This was recently a tunnel that was cleared out below the San Gabriel peak. And now that this duct is nice and clear, you can walk through this bile duct and enjoy the view of the San Gabriel Mountains above. I thank you very much.
That was great. Thanks, James. Lots of great tips, and I love the flukes or whatever those were at the end. That was great. That was classic.